lovelies, and welcome to today's video. My name is Alya and I'm so glad you stopped by. Today we're talking about one of my favorite things about my job, and that is intravitreal injections. I know it sounds crazy. An invasive procedure done irregularly to mostly elderly people that could potentially be so gruesome, so painful, so uncomfortable, but don't have to be. And I'll explain more about what goes on from an orthoptist point of view. So stick around to learn more about why we do injections into the eye. So it sounds really crazy that I would love a procedure that sounds so gruesome, right? It scares most people, just the thought of it. An injection into such a delicate organ. Is it dangerous? Is it painful? Is it like, what does it involve? And how could you possibly be so excited about doing something like that? Now, I'm not the one doing it, which is probably why I get excited about it. The ophthalmologist that I work for is actually the one doing it. In Australia, that's the rules. There are places around the world where orthoptists do this procedure, so that does kind of indicate how safe it potentially is. If you can get someone without a medical degree to actually administer such a treatment. Painful? Well, we do our absolute best as orthoptists and as clinical staff to make sure that when the doctor's actually doing the procedure, the patient feels nothing. We do have ease drops, and we do have, for some doctors, not all doctors, but we do have a subconjunctival anesthesia as well, and I'll explain everything as the video goes on. So we need to talk about a very important thing, which is the vascular endothelial growth factor. I believe it's called, or VEGF is what we refer to it. The medication itself is full of a special substance that is an anti-VEGF. In the more recent developments of this type of medication, or in the more recent versions of this medication, specifically trading as Lucentis and Alya, that's their common names, substance is very, very specific. And it definitely is not without its consequences and not without its risks, for sure, and the doctors will always be very hyper aware of that reality, but it's so effective. When I started as an orthoptist, we didn't actually have this technology at all. We didn't have these medications readily available to us. And when I was at uni, one of the main things that we would talk about is a low vision clinic. So, you know, a lot of people were going blind centrally in their central vision from this awful disease called macular degeneration, and there was absolutely nothing that could be done for them. But this VEGF stuff, it's a factor in the eye that creates vessel growth that doesn't belong. It usually happens because of some sort of degenerative process. So whether it be diabetes, for example, or a stroke in the eye, or more commonly, or the one that I see the most anyway, is through age-related degeneration. So the cells just simply cannot recycle. Rubbish, as I call it, or debris, builds up. That then causes these factors to come in to try and, you know, save the day by creating new vessel growth. Those vessels do not belong. Those vessels are not good. Those vessels will never save the day. What they do instead is they pop and leak inside the retinal space or underneath the retinal space and cause blindness, because blood in the eye is quite toxic to the eye and it just makes matters worse. So how do we stop this process from happening? We have anti-VEGF medications nowadays. Previous to them, we, like I said, had very little up our sleeve, and we would literally have to watch these people go blind, ironically. We are in much better days. So probably when I was out of uni, two and a half, maybe 3 years, we started to really regularly offer the predecessor to the common medication that was originally used in some sort of a bowel treatment. And, you know, doctors recognized that this was very effective, and they started to offer it for the eye. And after some research and, you know, the proper processes of checking whether it was safe and all that sort of deal, and whether it would be effective, they started applying it into the eye. Now, a lot of people ask me, can't I just take a tablet or something instead? Why do I have to get this really scary injection into my eye? And the answer to that is really very simple. There's only one major blood supply to the eye. There's probably something wrong with it if this is what's going on. That's the theory anyway. That's the standing theory. So can you really rely on it to carry medication to where it needs to go? Probably not. Also, do you want this anti-VEGF? Do you really want this growth factor to be subdued everywhere around your body, going via the stomach? Probably not. Probably that is actually quite dangerous to the rest of the body, or at least the really good thing about directly applying medication to the eye is you only need the tiniest little bit. I mean, we use usually 1 ml syringes. They're not very full. and the tiniest little thin hairline thickness needle to actually get it into the eye. So very little going on to the actual eye. The worst side effect that I've personally witnessed to anything like any of these procedures is subconjunctival hemorrhage, which is literally a red eye. Seriously, not a big deal. Goes away pretty happily on its own, doesn't need any help at all. It can feel painful and gritty sometimes as well after the injection, because we do make a really big deal about cleaning out the eye. So let's talk about safety for a minute. We are at the end of the day putting a little hole into an eye for a patient that probably doesn't have the best healing. So you could argue that that's going to be a recipe for disaster when it comes to infections and things like that. And you're right, you'd be right in assuming that. So what we do is we deaden the eye. I personally, for my patients, put 3, 4, maybe 5 drops of anesthetic if I have the time. First of all, they get a drop of anesthetic because I'm going to check their pressure always. Then they get 2, sometimes 3 more after I've done their scans. And then I'll do 1 more, or the doctor will do 1 more before they get an injection of anesthetic just locally to the site. And then they get their injection. So it's very, very much, you're completely numb. Now I mentioned scans. Very super duper important step of this process. Why we need scans is quite a few actually reasons, but the main one is because we really need to see about progress. No honest doctor is going to give an injection which is costing the government thousands, which is risky to the eye in terms of, as we just mentioned, risk of infection, if indeed it's not needed, it's not necessary, it's not working. And that sometimes does happen. Sometimes these injections don't continue to work, so we do have to stop them. Or the patient's disease is no longer progressing and they no longer require treatment. That can also sometimes happen, which is fantastic. So we do definitely have to remain honest and monitor the progression of the disease, which is very exciting to be able to do that, because now our scans, our monitoring is really, really good. So I first see what's happening at the back of the eye. If I know that the doctor is very, very likely to continue on with the procedure for that day, to actually do it, I give the extra anesthetic. They go into the doctor's office. She has a look. She has a look at the scans, looks at the patient, gets them into the procedure chair. Either myself or one of the girls in the clinic set up everything for the procedure, prepared the correct medication for that patient. Then doctor comes in, puts more anesthetic in, puts the needle of anesthetic in, and also cleans out the eye very, very thoroughly with betadine. Or for those who are allergic to betadine, we have an alternative. Now, betadine is fantastic. It's used for all surgeries everywhere, around everywhere. It's very cheap. It's very super duper available, and it just works. It's just the good stuff. I even use it on my dogs if they get a sore. I use it on my kids. Like, this stuff is just awesome. My grandma used it, like it's older than time. It's used in actual open surgery, things like, when they do deep tissue surgery, things like cesareans, whatever, they'll still use betadine to prepare the skin. That's how effective it is, and we use it on the eye. The really unfortunate side effect of that is betadine is very irritating to the eye, so that can sometimes lead to a little bit of post-procedural grit and discomfort. But the doctor I work with is wonderful. What she'll do is she will thoroughly irrigate the eye afterwards as well with some balanced salt solution, some sterile water, and just very thoroughly clean out any bleeding and any betadine that remains. So most patients are quite comfortable. She's also really quick, and she doesn't spend any extra time inside the eye. She's literally in there, out, really, really quick and easy, which is lovely for the patient's experience, and also minimal interruption to the eye. Very, very quickly, in Australia, anybody who has less than 6'9", which is 20/30 vision, that has diabetic changes or diabetic edema to the eye or swelling to the macula, has had a stroke or a branch retinal vein occlusion or branch retinal artery occlusion, for example, to the eye, or has had any age-related changes that has caused bleeding or swelling to the center of the eye, which is always known as macular edema, can receive either Alya or Lucentis. The way the doctors tend to go for it here is Lucentis is given to people who are bleeding inside the retinal space, and Alya to those that have it deeper in the retinal space or underneath the retinal space. That's not necessarily a rule. It's more of a kind of a trend or something like that doctors go for, because the research really supports it. There's no hard and fast rule about what the doctor will choose. They might have their own preferences, but that seems to be the going thing here in Australia. For people who have better than that vision, or have got more diffuse disease, they may also get a little bit of laser done. That's still very much done for the outside retinal growth or new vessel growth, and they'll still be able to access a drug called Avastin for the central part of the retina. Now, Avastin is the one that I first mentioned. When I very first started coming across these injections, that's all we had. Very soon after we got Lucentis, and then another 2 or so years after that we got Alya. So now the choices are abundant. Avastin is nowhere near as effective as Lucentis, and Alya is very similarly effective as Lucentis. It just works in a slightly different way. They say that Alya is more kind of powerful. I don't know that I've witnessed that, but I don't have such a huge patient base where I can run studies or anything like that. The literature tells us that Alya just runs deeper and is more long-acting or long-lasting. Sure, for some patients we definitely do see that generally, but it's not a rule. Everybody's growth factors are different, and everybody's disease is different, especially in the case of diabetes, where 1 month you'll see the patient and the disease is super active, and the next few months they might be really under control and you don't get much more progress, and you might even want to stop treatment for a while. So it really does differ. The other thing is, on these scans that I always do for the patients, we do definitely notice things over time. And I tend to be a bit of a sticky beak, and I say to the patients, what has changed? Because I want to know, what did they do different, whether positive or negative, so I can then pass that information on. 9 times out of 10, people who have made a drastic change to their diets do see a reduction in disease for macular degeneration. And we're talking about increasing greens, sometimes through powders or supplements, and sometimes just through diet, or keeping things regular. So even if someone's not diabetic, having an irregular diet can still put stress on the vessels in the system. So eating really well and cleanly does really help. Even if you're 80, it still really, really helps. Obviously, starting earlier can potentially avoid disease, but it's never too late. A lot of people come in and say to me, am I going to have these injections forever? In the case of macular degeneration, it's probably a yes. What I always say to the patient is, as long as we are helping you, we will continue to try to help you. That is always my answer, because frankly, we don't know if we're going to be able to help them forever. We don't know what their future holds, what other diseases they may get, or how they'll react to the medication. So I always say, if I can, and if doctor can help you keep your vision for longer, we will absolutely, most definitely be here for it. If we see that it's no longer helping you, we're not going to be risking, your health, even coming out here, the travel, because a lot of people, getting out of the house after a certain point in time, the mobility just isn't there and it's really hard for them. So we're not going to put them under extra risk if we're not going to see any reward for their efforts. So we definitely have that really honest conversation, usually from the 3rd or so injection. Now, the first 3 are absolutely pivotal, like they are the most important. The first 3 are always done 4 weeks apart. So first injection, 4 weeks later, second injection, 4 weeks later, third injection. So your first 8 weeks, get 3 injections. After that, if you're very, very good and you're holding down really, really well and the swelling is gone, doctor will probably extend you to, some doctors will go to 5 weeks, some doctors will go straight to 6 weeks, some doctors are happier to go even longer, but typically it's about a fortnight. Whatever works for the clinic as well. There are definitely logistics involved too, and what works for the patient and all that sort of stuff, but typically it's a 2-week extension. If that goes down really, really well and holds, you get another 2-week extension. So it's inject and extend, inject and extend. Now, sometimes patients say to me, if I'm doing really well, why are you still injecting? The reality is if, for example, a patient is doing really, really well, and let's say they're on a 6 or 8 week rotation, and we don't inject and we let them go to 16 without any intervention at all, that's going to cause a huge relapse every time. So it's always inject and then extend. Or what if we say, we'll review you in 2 weeks because we're going to extend today and and then inject, and then in 2 weeks time they're sick or they didn't make it or whatever, things happened. And then suddenly that becomes not a 6 weeks, but actually an 8 weeks. or 10 weeks or 12 weeks. You know, you can't control the future. So their best thing to do is to inject today and then extend next time. That is to ensure that the safety of the patient's health or the eye is actually kept. Because you've done all this good work to get them well, you don't want to risk it undoing. You see the term IVI, and that's an intravitreal injection. So the injection doesn't actually go inside the retina, it just goes into the gelatinous space inside the eye. So we don't actually sort of penetrate very much, it just goes through the white of the eye. Some doctors go at the very bottom, so just all the way down through here, or other way, get patients to look at their toes and all the way up there. So it's nowhere near the part of the eye that has all the muscles and fibers and things like that. It's literally like a skin injection in terms of how the eye is constructed. Now, last but not least, I do want to talk about risks. I mentioned that there were some, so I'm just going to read them out from the Macular Degeneration Foundation website. So we're talking about increased pressure inside the eye, inflammation inside the eye, infection inside the eye, bleeding inside the eye, and retinal tear or detachment. So rare, so rare. I've known of 3 patients in 12 years that have experienced that, and it's so avoidable by really good practice in preparation of the patient. So the betadine I mentioned, the extra anesthetic is really good because it stops patients from rubbing or jolting or any extra scratches or any other penetrations happening to the eye. And also sometimes we do recommend the patients use eye drops if they're particularly prone to irritation, because it stops them from rubbing their eye once it's been injected and introducing infection that way. But literally I've only ever seen it 3 times in 12 years across so many doctors that I worked for that do injections, and they all have different methods, and it's, like I said, only happened so very few times over the hundreds of thousands of injections that I've been a part of. But what is really, really common is seeing black spots, because that medicine is going into the jelly space of the eye, patients do see it. So they often do get reduced vision initially, but then within 24 to 48 hours, most patients do notice an improvement. But what does unfortunately happen eventually? Now, these injections do so much work to extending this day from ever coming. But what does happen is eventually the disease does catch up. So at the moment, there is a lot of work being done in how to slow down dry macular degeneration, so the actual disease that causes the bleeding in the first place. A lot of research always into diabetes and how that can be better controlled. And of course, interventions and preventative measures for things like strokes inside the eyes or occlusions inside any vessel anywhere. So there's a lot of work beautifully being done out there, and it's always so interesting in reading all the new articles and all the new theories and all the new testing that's being done out there to improve people's quality of life. It's definitely a passion of mine. I love how much progress we've made in the 12 years that I've been practicing, and I love that these patients end up becoming really, really regular, and we end up really getting to know them, and it's so rewarding to be able to help these patients that you end up seeing so often and end up learning so much about and so much from. Definitely grateful for all the progress that's available, and the fact that in Australia it's extremely affordable to be able to do this, at least through the public system, and in clinics like ours who participate in public programs. If you enjoyed this video and all the information and all the things that this channel brings, definitely hit that subscribe button. It's really encouraging to see slow and steady and beautiful, cute growth in this channel. Definitely encourages me to keep going, no matter the hour, no matter the day, no matter what's going on. So definitely subscribe. Head over to Instagram for cute reels of dogs and cute photos and everything else that goes on in my hugely busy life. And wherever you are around the world, my lovelies, I hope you're doing really well, and I'll see you on the next one. Bye.